multi-channel BP. So much more, like we can spend the whole day, 2 days on just understanding the various things that VPs can do. So the flash retinogram, as we understand from the physiology point of view, it basically measures the change in the resting potential of the eye, which is induced by a flash of light. And this will result in a biphasic waveform, which is then recorded using the electrodes, and we get that waveform on the monitor. So the good thing is that as the retinal function deteriorates, once it, the cells of the retina are not functioning, this electrical activity will, reduce. And this reduction, fortunately, is very substantial. It's not like few micrograms. Like if normal is 300, it won't become like 220 or 250. It will come down to less than 50 or something like that. So the response is quite substantial, and so that is why it is such a robust technique to study this visual functions using the electrophysiology. So what happens is when the light falls on the retina, then there is photoisomerization of the rhodopsin and other photochemicals, and that will lead to hyperpolarization of the photoreceptors, that is the rods, cones. And then one may think that why we have all these other channels. Why isn't it that just the rods, cones get they get stimulated, and then directly why doesn't the signal go to the brain? The reason for this is that the retina itself, that is the bipolar cell layer, which is we call it the inner retina, has lot of processing of these visual signals. Without this processing, we would just see very faint pictures. Maybe there would be some high resolution, but we would not see like motion or contrast or details of that object. So all the processing happens in the bipolar cells, amacrine cells, horizontal cells. They process this image so that there is a center which becomes enhanced, and it will suppress the surround. So there's a lot of processing happening, and that is why these bipolar cells are very important, the Muller cells, bipolar cells, because they process this image. And also these bipolar cells are different types. There are those which are on the on pathways, there are those which are on the off pathways. The maximum majority are the L and M cones. The S cones are very smaller contribution. But if the L and M cones are dead, then the S cones will take over. So so there's a lot of processing which is happening in the inner retina, what we call as the inner retina. And then this processed signals are given to the ganglion cells. And then the ganglion cells will further process them and pass them on to the optic nerve. So this is very important to understand, that there is a continuous chain, and that second order neurons, which is the bipolar cells or the inner retina, is the processing machinery. So it's not just a signal transmission from A to cortex. So then the direction also matters. As you see, the retina is highly organized, and it has so many cells, and some cells we still don't know what are their functions, and the physiology is still evolving in many areas. But what we know is that those which are radially arranged, where the light directly falls on these cells, then they will have the maximum contribution to the electrophysiology. Whereas if they are horizontal cells, they contribute less. But so it will depend. So in sometimes if there is a disease where the cells which were supposed to be horizontal, they have become laterally displaced, then the amount of signal you will get will be less. So the waveforms which we see, I'm not going to all the details, but basically the different parts of the cells, that is the photoreceptors and this pathway, they will generate the waveform. So important to remember is that the A wave of the flash electrophysiology is generated by the photoreceptors, and that's the only cell in the eye which can respond to light. Everything else is a process signal, and then these are passed on to the bipolar cells, which then generate the B wave, which is from the inner retinal function. So if the test is carried out in dark light, then it will stimulate the rod pathways, and if it is in bright light, which is called the photopic response, it will stimulate the cone pathways. So this is just to again tell, when you're looking at the response and you're reading an ERG, always remember the vertical organization and the serial organization of the retina. So the retinal pigment epithelium we study by EOG, but the retinal pigment epithelium doesn't have any light sensitive cells. Okay, this again we have to remember, there's no light which falls on the RP and generates signal. The generation of the signal from light is in the photoreceptors, and they influence the potential of the RPE, and that is how we study the EOG, which is an indirect function of the RPE modulated through the photoreceptors. So if the photoreceptors are not functioning, you cannot use the light method to study the EOG. And then the photoreceptor, I already said, the A waves from the outer retina and the B wave from the inner retina. Whereas the macular function we study by the either multifocal ERG or the pattern ERG. So the flash ERG will not tell us about that. And then the ganglion cell functions we study with the N95 of the pattern ERG. And from optic nerve chiasma to vertex, the visual cortex we'll study through VP. Again, the VP has to be studied only if the photoreceptors were healthy and generated that signals. If the photoreceptors, the retinal disease is already there, your VP will also be abnormal. So it is like a cascade that you have to know the pathways. So the normal flash ERG, as I said, in the dark and light, it is dominated by the rod response in dark, and in the light, the cone response is dominated by the L and M cones. Now, if the S cones are there, which are only a small percentage, they don't contribute too much. But if there's a disease where there's only S cones, then it will enhance. So how do you study this S cones? How do you find out the S cone response? So here you use a calorimetric or a colored ERG. You can put an orange background. This will take away the rods. It will take away the element cones, and you will enhance the S cone response, and so you can study. So this is what will happen. A normal ERG will give this as the photopic response, but in an orange background with the blue light stimulation, which enhances the S cone, you will get an enlarged S cone, and also the waveform will get simplified. It won't have any notches. It will just be one down wave and one up wave. So, but of course, most of us don't do this S cone response, but we can study it. So I'm just trying to highlight that once you have the knowledge from where the signal is coming, you can study even right up to the S cone or LMN cone, or not only the rod. So this is just to highlight, Deepika has put this together. So a normal ERG may look like this, but in a disease where there are no L and M cones and where the rods are also abnormal, there it's an enhanced S cone syndrome. The rods are not functioning, so you can see there's no rod response. The flash ERG to dim light and bright light, they look exactly the same, because now the whole retina is replaced by S cones. And then of course the amplitude, as we said, the S cone amplitude will be higher than the flicker amplitude. So this is just to say that if we know from where the signals are coming, we can study these conditions, and that is why, although it is an enhanced S cone, S cones are photopic cones, but the patients present with nyctalopia, they have night blindness, because it's all the other systems are not functioning, especially the large parts of rods are not functioning. So this is how the enhanced S cone syndrome will look like, although it will look like retinitis pigmentosa, but your ERG will tell that this is not RP, this is actually enhanced S cone syndrome. So coming to pattern ERG, these signals come from both the ganglion cells and from the photoreceptors of the macula. So it will help us to know that the initial positive wave is from the retinal photoreceptors, mostly the macular photoreceptors, whereas the N95, which is the second downward going peak, is from the ganglion cells. So it can be used for glaucoma, or it can also be used for ganglion cell toxicity studies. The multifocal ERG, these come, so initially it was thought that they come from the cone photoreceptors, but then animal studies by David Hood and all have shown that actually it's not true. A lot of these signals of the multifocal ERG are actually coming from the on and off bipolar cells. That is, these are process signals from the inner retina, and only a small percentage is the direct signals from the rod and cone photoreceptors. Still more details are awaited from where do these signals come, and they are not just like tiny photopic responses, they are different. So this is just to show that in multifocal ERG we have various signals, and then the retina is processing these signals and then giving us the final signal based on what was the stimulus condition before and after. I think Praveen Sen will talk more of that. In EOG, sometimes people get confused. So EOG is a big response. This is in millivolts. The ERG was in microvolts. So when you study responses, you should look what is the scale. Okay, this scale is in millivolts, but the ERG is in microvolts. And here what we are doing is, since there are no photoreceptors in the RPE, the photoreceptors generate the signal and they change the electrophysiology or the electrical signals and the chemicals around the RPE. So the RPE has a resting potential of about 6 millivolts. And when the light is put and this chemical change happens around the RPE, then the RPE voltage goes up. And this is called the light rise. So we should see for the light rise, that light has gone up, and then the signals will go up. And so to say about the VP, these are the signals which are generated from the occipital cortex or the visual cortex. Okay, so now all these signals can be affected by the physiology of the eye, by the technical things like how are the electrodes placed, what type of machine we are using, and of course by the variation in the disease pattern. So important physiological changes, when we are recording, we should note down all these parameters, otherwise we will make a mistake in the interpretation of these. So to conclude, visual electrophysiology testing has gone from a global, complete whole mass retinal response to regional areas and to cell-specific responses, and origin of most responses well illustrated for clinical interpretation. However, there is more quest ongoing in the labs for in-depth understanding of many of the responses which are still not very well understood, and we hope that they'll be understood over a period of time. Whatever we have learned has not happened in one day. It has happened over at least 100 years of knowledge by various scientists who have elucidated in animals and then in humans that what are these responses, where from they are coming, and how they are affected in disease and health. Thank you.